associated with healthcare or being in the healthcare delivery system. How many of y'all in this room have worked in healthcare before you come here? So, probably about half or 2/3 have had prior experience. So some of this may not be new to you, but it's always a good idea to go over it again. Every career that you choose has certain risks associated with it. If you work, if you decide that you want to spend your life in public service in either fire department, or you work for a police department, that's pretty high risk, and that's pretty well defined. But there are risks even if you work in a department store. There are risks when you work in healthcare. It's not like this is a place where you're going to develop infections and have problems. It's very, very rare that we have an employee develop an infection. As a matter of fact, it's super rare, except maybe for the flu. So we're going to talk about some of the risks that you'll find when you get into healthcare and how you mitigate those to reduce your risk. So, as we run along through this, ask questions, hold up your hand, just shout it out, whatever you want to do. Over in the far corner of the room, I can't even focus with my glasses. So, if you have to say something, I'm getting on the edges. So we're going to talk about infection risk. We're going to talk about standard precautions, and we're going to talk a little bit about isolation precautions today, realizing that this is a high-level overview. So, and the idea is that you have some sort of vague understanding from my rambling presentation about what your risks are. Okay? We'll go with that. So there are a lot of risks in healthcare that are infectious disease related, and we're going to talk about a few of those as we go through. How many of y'all, first of all, have seen Star Wars, the latest version of that? How many? Not that big. How many were really excited when you walked out? It was okay. I mean, it was a couple of 2.5 hours, and it wasn't the best movie I've seen in the last 2 weeks. Okay? I still have a young kid at home, and I have a college kid, and we go to a lot of movies. It's not the best movie I've seen. The good news about my presentation today is that it won't be as long as Star Wars, okay? And it may be as exciting. I don't know. It just depends on how this goes. So, now what that has to do with HIV and AIDS, I have no idea. But y'all can assume whatever. Maybe this is more exciting than the active shooter. I don't know. But, well, y'all know that HIV causes AIDS. Hepatitis B causes acute chronic hepatitis. If your urine looks like Coca-Cola, that's not normal. You should seek help. Hepatitis C causes chronic hepatitis in 3 out of every 4 people who are infected. So the rule for hepatitis C, if you're infected for life. So, in a healthcare setting, the risk of you acquiring these viruses are, number one, a splash to the mucous membranes of your face. You can be infected through your eyes, nose, and mouth. You can be infected through broken skin, through a cut on your hands, through you just had your ears pierced. I've been thinking about that, but can't quite figure out how to make it work with my baseball cap. And your biggest risk is a dirty sharp's injury when that sharp has been in someone who has one of those viruses. So, so what are your real risks if that type of situation occurs? For hepatitis B, it's incredibly high. I made this up. but it could be 30 to 50, it could be 40 to 60% risk of acquiring hepatitis B in a healthcare setting. For hepatitis C, it's 2 out of 100, which is pretty high. And for HIV, luckily, in a healthcare setting, it's relatively hard to transmit. 3 out of 1,000 healthcare workers who have that dirty sharps injury acquire HIV. Now, to them, that's 100%, because that pretty much is an infection for life. And back during the first 5 or 10 years after HIV was defined, that was a death sentence within the next 5 or 6 years. But now with HIV therapy, it can be a chronic infection versus a almost certain life death sentence. So still 3 out of 1,000. Now, the good news about hepatitis B is that there's a vaccine, and hopefully you've all had that. It's very effective, about 95% effective. And if you were lucky enough to be tested after your vaccine series and know you have antibody, you're considered immune for life to hepatitis B. Very safe vaccine. It's now a childhood vaccine. So, great vaccine. So, back to HIV and these other viruses. I don't want you to think it's hard to catch HIV. Now, there are risks out in the community that we don't have at work. If you're an IV drug abuser, raise your hand. If you are, do not share dirty needles with other people. That is, you will catch these viruses. So that's a risk. Unprotected sex. The risk of acquiring HIV and hepatitis B is incredibly high if your partner has one of those viruses. But that's not a risk at work. We're Baptists. We don't do that here. So, but do not walk out thinking it's hard to catch HIV. So, we don't do this. So, bloodborne pathogens. They are a risk at work. There are ways to protect yourself. The risk is real. So we don't want that to happen. Okay, let's move on to another type of infection. Totally different. Totally different. Tuberculosis is a airborne disease. That means it's spread by breathing in the air that someone with the disease has been in and has been coughing into the air. Say Larry, who did the active shooter drill or discussion before your break, had tuberculosis, and I don't know if he actually presented, he talks kind of deep, kind of rough, kind of tough guy, well, okay. Let's say he had tuberculosis and he coughed all over the room. You could actually acquire tuberculosis now by breathing his airspace. So that's an airborne disease. You breathe in the air, the bugs are floating in the air. It has an incredibly long incubation period. It could be decades. It could be 40 to 50 years after your initial infection. So long incubation period. Usually presents as a chronic lung infection. The earliest onset is usually at least 6 months after exposure. So very long. These are some symptoms of tuberculosis that are on the slide, and I think that's in one of your post-test questions, just FYI. So, airborne disease. Flu, you know about. Flu is everywhere right now. This is probably the worst flu season I can remember, including the H1N1 pandemic, probably. I forgot to get the actual count of flu patients we have in our hospitals today, but it was out of sight yesterday and the day before. So, and the number of cases coming to our ERs are pretty incredible. Last year was a bad season. This year has already exceeded that last year. It's highly contagious. It has an incubation period of 1 to 4 days. although typically like 2 days after your exposure is the onset. And the tricky part is that, bless your heart, you can have the flu right now. And you could be exposed. You could have been exposed 2 days ago, and you could be incubating the flu. If you're going to come down with it tomorrow, you're infectious this afternoon before you know it. So that's the tricky thing about flu is who caught it? So you don't know who they are. So you obviously know someone who looks like they have the flu and are coughing profusely, but you don't know what you don't know. The problem of you're most contagious right at onset or right before onset. Antivirals, the brand name of Tamiflu it is helpful if you do get the flu. So I would encourage you to, if you think you have the flu, to go to your doctor or call them to get tested, and also to maybe get some Tamiflu. It'll cut down on the duration of illness, if nothing else. I don't want to talk about pandemics. I don't want to talk about that. This little chart is actually from a flu year a couple of years ago. I'm trying to think if that's similar to this year. It's pretty similar, except that the season started back in October. So we've had cases all the way since October for this season. We've really, really peaked before Christmas in December, and the question is whether it's going to stay up. Typically, the flu season resolves at spring break. So hopefully it will start trending down before then, but right now we're still really up on our peak. So flu is spread. So how do you catch flu? It's spread by the droplet spread. Tuberculosis is airborne spread, but flu is spread by large droplets that you cough out, but these typically fall to the floor in like 3 foot. So if you think somebody has the flu, just take a big step back. So just avoid that coughing person. If I go to a restaurant during flu season, I kind of circle through the restaurant around tables where there's somebody coughing. You can catch the flu from being coughed on, but also touching surfaces that someone who's coughed on their hands and then touched the surface. So keep your hands out of your face. It's okay if it gets on your hands as long as you don't go to your face. So either, whatever you want to do. Or you can do hand hygiene every now and then. That'd help too. How about that? So, especially around the hospital. I didn't want to talk about those. And if that's not enough to worry about, you have to worry about bacteria. So, common bacteria that you run into around the hospital, the most common is Staph aureus, which is a bacteria that causes chronic wound infections, it causes pneumonia, bacteremia, you name it, it pretty much causes it. If anybody's ever had a cut or wound that's gotten infected, it was probably Staph aureus. So we see a lot of patients with Staph aureus in the hospital. And it can be spread by touch. You touch something that's contaminated with Staph aureus, and you touch broken skin or your face, and you can be infected. Or you can touch someone else and they're infected. Strep pyogenes causes strep throat. We rarely see that in the hospital, except in the ERs where kids come in with strep throat. So, but most of you have probably had that during your lifetime. And if that's not enough, we have versions of bacteria that are antibiotic resistant. So Staph aureus that is resistant to multiple antibiotics is called MRSA, methicillin-resistant Staph aureus or multi-drug resistant Staph aureus. And then resistant strains of a bacteria called Enterococcus, and also not really an antibiotic-resistant bacteria, but a bug that causes disease in people who get antibiotics is Clostridium difficile. How many have had experience with Clostridium difficile or been around patients with it? It's one of these where you can tell it walking down the hall, right? So the best diagnostic test is a sniff, very distinctive. So, and lo and behold, you got to worry about bioterrorism. I mean, bioterrorism is an attack with an infectious agent. It has a very subtle onset for the first 24 hours if you have one of these type infections. And for the first few hours, all of these look like the flu. Now, if we had a bioterrorism attack right now, and maybe that's why we're having a spike, I don't know. You wouldn't think about it, but in July you would. So, very subtle. For the first day, it may look like a flu outbreak, but that quickly changes. So, the agents that we're talking about, things like plague, anthrax, the viral hemorrhagic fevers, which are less likely, that would be like Ebola, which we had a big Ebola scare a few years ago, or smallpox. These are not infections that you think about every day, but somebody has to think about it a little bit, pretty much every day. So these people get sick and they come to hospitals. So, I guess my choice as far as spread person to person would be anthrax, because it doesn't. If you have anthrax, I have to worry about taking care of you, but I don't have to worry about getting infected from you, because it doesn't spread person to person. Plague, the viral hemorrhagic fevers and smallpox do spread person to person. So you have to worry about taking care of the patient, and you also have to worry about spread to other people. And then there's the rare new disease that crawls out of the jungle, or out of a chicken in China, or a deer in North Arkansas, and creates a new disease that jumps to humans. And we constantly have emerging diseases that we have to monitor. We have an on-call person for infection control for the system, and we have a standard deal for admissions to the hospital. A question that we ask: have you traveled out of the country in the last 30 days? And then, where did you go? And if a person presents like that, they have to page whoever's on call, and we check that against a watch list of current emerging infectious diseases. So it's not a casual thing that I just put on the slide. It actually is something that happens every day. And what's really irritating is somebody calls you at 3 a.m. in the morning, and somebody's been to the Bahamas or to Italy, which, it just makes you jealous. So, MERS is a disease in the Middle East. Kill your camel if you have a MERS outbreak. Avian flu, get rid of your chickens. So, all these helpful tips right here is where you heard it. So, if there's an avian flu outbreak, sell your chickens, put them outside. Don't let them run around in the living room like we did when I grew up. So, how are you protected from work from all these horrific things that are out there in the world of infectious diseases? Good question. Well, standard precautions will protect you from about 95% of these events. That and a little bit of common sense. The standard precautions was developed, the concept was developed after HIV was identified or discovered, however you want to phrase that, as an approach to patient care to make sure that employees are safe. Does anybody know about the year that HIV was first identified? Not virally, but the first cases occurred. 1980s, early 1980s, I think 1981. I was in Chicago at a meeting, and these cases of unusual infections were described in California. And that were the first case reports that eventually were later identified as HIV. The Centers for Disease Control, in the first year, even before the virus had ever been identified, set up a set of precautions for healthcare workers, and those have not changed. And it still works. So, standard precautions. So, the idea is that you treat everybody as though they have whatever scares you. What scares you? Anything? I don't think anybody, anything scares her. HIV is the typical. So HIV, some people say head lice, whatever scares you. Assume that everybody has it. So assume that everybody out here has HIV. My gosh, what have y'all been doing? But let's just assume it. So the deal is, there's certain basic things you can do to protect yourself while you're taking care of patients. Those are like hand hygiene, use of barriers, and don't stick yourself with something sharp. If you don't do anything, if you don't focus on any of the things I say today, and you probably won't, but remember hand hygiene. That is your biggest protection against infections of all types, especially the flu and all these other viruses and Staph aureus. And it's the single most important thing you can do to protect yourself and your patients. So just cleaning your hands after you touch all this grody stuff, or after you take off a pair of gloves, or after you go to a restaurant or in a public place where you touch surfaces. That's going to protect you just out there in the world. We coach our patients to challenge you when you enter a room or a procedure area if you don't do hand hygiene. So be ready for that. And if they challenge you, then repeat hand hygiene in front of them so they can see you do it. There's a couple of ways you can do hand hygiene. First of all, hand washing is always okay. It's always appropriate to wash your hands. You don't always have to wash your hands with soap and water, but it's always okay. You should always do it after leaving, and this is actually wrong, after a special contact precautions room. You should use it if your hands are visibly soiled. You should wash your hands. If your fingers stick together, alcohol products aren't going to help. Obvious times, after you go to potty, before you go home, wash your hands. Really? Come on. So sometimes you have to wash your hands. But other than that, you can use either the alcohol foam or gel to clean your hands, and it works just great. And there's a zillion indications for doing hand hygiene using alcohol foam. The big deal is before you have patient contact and then after you have patient contact. You should always do hand hygiene, and usually, except for special contact or grody hands, the alcohol products are okay to use. So when you enter a patient room, you should go to the alcohol foam. It's going to be mounted on the side of the wall. Get a shot, start rubbing your hands while you're talking to the patient or before you put on gloves. After you take off the gloves, that's assuming you need gloves. That's not an automatic. You can touch a patient without a pair of gloves. It's just if there's a chance of getting blood or body fluid on your hand, then you need to wear a pair of gloves. Okay? So, if you need gloves, you still have to do hand hygiene before and after those gloves. The alcohol products are very effective. This is a couple of Petri dishes. We had somebody stick their hand on it, on the dish before alcohol. When we get alcohol, stuck the hand on it. It's just a visual way of showing how quick and effective alcohol products are. And I made the point about gloves. You have to do hand hygiene even if you wear a pair of gloves. If you don't do these things, then it doesn't matter how you do hand hygiene, you can't do it correctly. If you have a pair of those fingernails that didn't grow naturally from your body, you made a decision not to be in healthcare. You cannot have direct patient contact. I can grow trees from underneath those fingernails. So, literally, almost literally, or at least grass, if not trees. So, you have to do these things appropriately. You can certainly need to use hand lotion, and at home, please use your own hand lotions, but at work, please use the ones we supply. They're guaranteed not to interfere with our soaps. They used to smell like urine. People objected. I don't know. They improved it. It smells a little better, so please use our hand lotion and not yours. Some people like the smell of urine. I don't know. If you work in the lab, you get used to all sorts of stuff. Please remember to eat and drink in the right places, and that's not in patient care areas. Lounges, cafeteria, in your classrooms if they'll let you. It's all good, but please not around patients. They're sick, and they can make you sick, and also you can make them sick if you get slobber off your coffee cup on your hands and touch the patient. So, keep your eating and drinking away from your professional life. Okay, so hand hygiene. We talked about that, doing a little eating and drinking, which has nothing to do with it, but what the heck. The other big part of standard precautions is use of protective equipment. The idea is put a barrier between yourself and that patient exposure, or that blood and body fluid exposure, and you use whatever is required. If you're starting an IV, then it's reasonable that you might get blood on your hands. You should wear gloves. You don't have to wear a gown. You don't have to wear face protection. Okay? If you're doing a job where you're cleaning up a bed and the patient had diarrhea, it's reasonable to expect you're going to get stuff all over your clothes. So gown and gloves. Whatever it takes, you should put on barriers to keep that blood and body fluid off of you, out of your face, off your hands. If that's in surgery, that may include shoe covers, it may include boots. So whatever it takes, we have to provide it, and if you're smart, you will wear it, and also that's not really an option. We have to require you to wear PPE for your own protection. It's not like it's not a democracy. I'm sorry. If you're in a situation where you have to wear PPE, then you have to wear PPE. This is Bruce. He works in the bronch lab, and people cough in his face all day long. He's got on gloves, an impervious gown, a mask with a little plastic eye shield, so he's pretty much protected. Eyes, nose, mouth, hands, scrubs. So if you're working a nursing unit, some of your PPE, you'll have to find out where you are. Or when you're up doing rotations, your coordinator will help show you where PPE is located. Gloves, all the alcohol products are everywhere. Gloves are in patient rooms. When you enter, there'll be multiple sizes. Gowns will typically be in the linen room or outside isolation rooms. Face protection will be usually in a central location unless you work in ICU, where it would be in pretty much every room. So, but your coordinators will help you find your stuff and will show you how to appropriately put it on and use it. Also, they will show you how to use sharps and make sure that you engage sharp safety devices correctly. You can defeat almost any safety device, but we don't want you to do that because then you become an exposure, and you will be monitored for infection for a while after that event. And that's not something you really want to go through. If your sharps container looks like this, avoid it. It's overfilled. You can get stuck throwing away a sharp in a container like this. If you do have an exposure on the job, whether it's a sharps injury or a mucous membrane or splash to your face or to broken skin, contact your student coordinator immediately. I know there's some forms to fill out, and there will be arrangements will be made to test the source patient to make sure that they're not infected with one of those three viruses. Do not wait. If you have an exposure on Friday afternoon or you're working nights, do not wait a day or two before you report your event. For HIV, the window for prophylaxis likely working is 72 hours. So what we try to do is start prophylaxis for HIV in 2 to 4 hours after the event. So that includes you going, oh goodness, I've been stuck. Filling out some forms, contacting your coordinator, employee health or your coordinator working to make sure that the source patient is tested, getting those results back and delivering medication to your person. So 2 to 4 hours. So do not wait. Do not hesitate, okay? There's always someone on call for infection control, yes, but employee health for the system. If your coordinators have questions or need help arranging to get a source patient tested, there's always somebody available. So it doesn't matter whether it's Saturday, Sunday, Friday night. There's always somebody available to help. I don't want to talk about that. Okay, so for some patients, standard precautions just isn't enough. And we have to add another layer of precautions, and we call these transmission-based precautions or isolation precautions. And there's basically 4 types of precautions: contact, special, airborne, and droplet. For contact and special contact, basically it's gown and gloves when you enter the room. So from your point of view, it's pretty much the same. Airborne, I do not think you go in airborne precautions rooms. You have to be fit tested with an N95 respirator, and I think that's the understanding we have is that students don't do that. And droplet, which if you're out on the units now, probably about 5% of the patients are on droplet precautions for the flu. You put on a good quality surgical mask when you enter the room. For anything working around secretions, you put on a pair of gloves and do hand hygiene when you leave the room. Be sure to do hand hygiene before you take off your mask. You know why? Because you can infect yourself from your hands. So even though you're going behind to tear or untie, and also do not pull down a surgical mask and leave it around your neck for the same reason. If someone's coughed in your face and got it on the outside of the mask, you can infect yourself from the surgery mask. So the patient's on droplet precautions. When you're done, take the mask off and throw it away. Do hand hygiene before you go to your face ever. Okay? When you get in your rotations, your coordinators will show you the different types of isolations and the signs. So contact is a yellow sign, black lettering, special contact, yellow with red lettering, green sign on the door is droplets, and airborne precautions, just stay out of the room. It'll be a hot pink sign on the door, and N95 respirators required for entering the room. If you doubt anything I've said, and you should, look on EmployeeNet. You've probably been shown or will be shown how to use EmployeeNet. Down the left side of the page, under policies, click on that, it will drop down to infection control, and all the policies for our facilities are there. That would be your resource. If you have questions about infection control, you can always call the on-call person. Just dial the operator and they'll connect you to somebody pretty much 24 hours a day, 7 days a week. Let's go through your post-test real quick and we'll be done. It is on the 4th page. And so number 1, true, false, hand washing is required if hands were visibly soiled. True. Specific actions I can take to reduce infections are all the above. The 3 ways of being infected with bloodborne pathogens on the job include BCD. The name of the infectious disease policy for all patient contacts is B, standard precautions. After an exposure to blood or other body stuff, healthcare workers should report exposures to your student coordinator. I'd call my mom too. Use of sharp safety devices, all the above. Personal protective equipment, again, is all the above. There is no, as an employer, we have no choice but to mandate that you wear protective equipment when appropriate. It's not a choice, or we're legally responsible. So isn't that nice to know that I'm legally responsible for you? Doesn't that make you feel better? Oh, yeah, okay. The most important means of preventing infections in patients and healthcare workers is